So today I'm here to talk with you about HIV. Of course, as I said before with hepatitis, I know that you are very, very, very familiar with the subjects, probably more than I am. But I will talk, I will like do a general introduction of the subject to share our techniques, our clinical approach, and then we will, as we did last time, compare our different approaches, and you will tell me what you usually will tell us what you usually do in these cases. So I know that everybody knows that HIV is was discovered, made its first appearance in 1981, and that is a very important problem worldwide. We know that there is a burden in many countries related to HIV. We know that there are almost 37 million adults and 2 million children that live with HIV or AIDS every day. And every year, almost 2 million adults and 15,000 children get infected. We know that the prevalence in the last years became stable. For example, I know that there is almost 1% of the world population that is infected with HIV, but we know that the new infection rates have dropped in the last 20 years, almost by 50%. So we have 1.5 million infections every year, and in 2001 we had almost 4 million infections. So this is a great result. Of course, related to prevention techniques, to sharing information that got HIV very well known by the general population, different than was 20 years ago. What we know that HIV is spread everywhere in the world, but there are some places where there is more prevalence. The more HIV infection, almost 2/3 of HIV infection are found in the Caribbean and in sub-Saharan Africa. There are many countries in the Southern Africa that have a prevalence of almost 25% of the other population. Of course, we know that in the last years, the situation is improving. We have stability in the rate of contagiousness, and it is shown that new cases of HIV are declining in Africa too. And we know also that mortality rates have dropped in the last 10 years because of therapy, of course. And we know that 10 years ago, HIV was one of the first 10 causes of death in the world and one of the first in sub-Saharan Africa. We know there are many countries where HIV is widely spread. We have talked about the Caribbean, that have the second highest rates in the world for prevalence, and there are other countries where HIV is less represented. We have Asia and the Pacific Islands, where the prevalence is lower than 1%, and US, where the prevalence is also lower than 1%. Mostly, it is shown that this infection in African countries are related to heterosexual relationships, and in US, the most part are related to homosexual relationships. In Europe, also the prevalence is around 1%, but we have a rising in the eastern countries, such as Russia, such as Ukraine, mostly caused by heterosexual intercourse. We know also that HIV can be transmitted by different fluids. Of course, The main transmission is blood, but we have also sperm, vaginal fluids, and breast milk that can be routes of transmission of the virus. It is not possible to be infected with HIV with saliva, with sweat, or other bodily fluids. We know that the largest part of transmissions occurs through heterosexual contact. This is the first cause in Africa and in Eastern Europe, but we have also a prevalence of men who have sex with men in Western countries mostly, because this kind of relationship can have a higher risk of infection. And also drug injections, because in Western countries, almost 30% of HIV infection are related to drug use. One other thing we have to talk about is mother-to-child transmission. In fact, every year, over 2 million infants are born from HIV-positive mothers, and 90% of children get HIV infection via mother-to-child transmission. Of course, this transmission can occur in uterus or at birth or via breastfeeding. So it is important to watch for HIV-positive mother. Of course, you know that better than I. What we have to talk about generally very quickly about the virus, because the virus, the HIV virus, is an RNA virus and has a particular structure. This is important, not because we want to talk about the microbiological aspects, but because many of these parts are targets for therapy. So we have envelope proteins, GP120, GP41. We have enzymes such as reverse transcriptase, integrase, and protease, and 2 copies of RNA. Of course, this virus attacks CD4 cells and can attack these cells in different ways, from direct damage and also by defects of production in bone marrow, and also of disruption of lymph node structures that can be related to HIV and also to HIV-acquired malignancies such as lymphomas, for example. This is important because we can see here the course of HIV infection. Of course, once somebody gets infected with HIV, there will be some weeks where there won't be any symptom. It is possible to have an acute HIV infection around 3 to 6 weeks from infection. Then we will have a period of no symptoms at all, and then the opportunistic infection will start. So we will see each of these parts quickly while I talk about the course of the infection in the next slides. The timeline is this one. As I said, we have the transmission, then we have the acute infection that is called also seroconversion syndrome. And it is the point when the patient has got the positive HIV antibody tests after around 4 to 10 weeks from infection. And then we have the latent HIV disease that can be chronic with or without AIDS. And then we will see what are the criteria that, according to WHO, define AIDS. We will start, of course, with the acute infection. I used here the classification in groups according to the CDC. There is also the WHO classification that uses 4 different categories of symptoms. So asymptomatic infection, mild symptoms, intermediate symptoms, and AIDS-defining conditions. This is in the WHO classification, the part when we talk about asymptomatic or mild symptoms infection. This acute HIV infection occurs within 6 months from the contact that infected the patient. The main feature of this acute HIV are fever, lymphadenopathy, sore throat, rash, malaise, symptoms that can be associated also with mononucleosis, so it is called also mono-like symptoms. But it is important to know that 60% of these people are completely asymptomatic. So this kind of presentation occurs only in 40% of the people. What we have, what can we find in the laboratory findings? We can find a high viral load, because in this moment the HIV virus is infecting the CD4 cells, and also as the weeks progress, we can find different positivity to different proteins, as shown by the next slide, where I have put the Fabic table, that is a table that can show how, as the infection progresses, we can see the positive test for HIV RNA, the positive test for the PU24 antigen, and then we can start to see after the appearance of EGM, of different parameters that can be related to different phases of acute infection. In the acute infection, as I was saying, there can be other symptoms that here are referred as group B. So we will talk about WHO mild symptomatic infection, as for example thrush, so oral candidiasis, persistent vaginal candidiasis, fever, diarrhea. I'm not here to read them all, but many symptoms that can get the physician to suspect clinically that this patient is having an HIV acute syndrome. Then this period is followed by a long period of stability. The patient gets better without or with mild treatment, with symptomatic treatment, and if he doesn't discover that he has HIV, he can be totally fine for about 8 to 10 years. This is the time that most people use to reach under 200 CD4 cells without antiretroviral therapy. This stage can be also characterized by the appearance of comorbidities, for example, diseases in the cardiovascular systems, malignancies, or cognitive disorders. But this is not for everyone. In fact, the most part of the patients are totally fine and don't have any symptoms until we have the start of the opportunistic infections. What is AIDS? According to WHO, AIDS can be defined from a CD4 cell count of less than 200 cells per microliter, or any AIDS-defining conditions. There are many in the next slides. And this condition can be used to diagnose AIDS without a CD4 cell count. Of course, this condition, AIDS, is not for life. In fact, when with therapy a patient gets better and achieves the resolution of both of these criteria, this patient has overcome AIDS. So is only HIV positive. Average survival of these people without ART is about a year and a half. In addition, of course, if someone starts ART in this period, so when the CD4 cell count is very low, there is the risk to develop a syndrome, so the immune reconstitution syndrome, occurring from 6 to 12 months after the start of the therapy. This syndrome, of course, is caused by the rapid increase of the lymphocyte level, and can be related to damage to many organs. This is the list, of course, the long list of AIDS defining condition. These conditions, of course, are related to every part of the body, are neurological conditions, respiratory conditions, infections, malignancies, and a lot of other syndromes that can define AIDS. We will talk about some of them briefly, just to have a general idea. Neurological complications are, of course, related to the direct damage that the virus can do to the CNS cells, but also by opportunistic infection related to the CNS. Main complications I am going to mention, not all of them, but some of them, are the AIDS neurocognitive disorders, cerebral toxoplasmosis, meningitis caused by Cryptococcal pneumonias, CNV encephalitis, and the primary neurological lymphoma. So the first one is the group of conditions that are called HIV Associated Neurocognitive Disorders. These are the group of conditions that are related to the direct damage of the virus to the brain cells. That can be divided also into 3 subgroups. Of course, there are asymptomatic conditions. These conditions are called ANI, only seen in neurological tests, but not in the everyday life. So these people are completely fine and don't have any problem, any impairment in their daily activities, but they have an impairment shown by neurocognitive tests. In the second part, we have mild neurocognitive disorders, so a group of disorders seen in the everyday life and in neurocognitive tests that can become HIV-associated dementia. This is a syndrome that is widely represented in AIDS people. Almost 5 to 7% of them have symptoms like that, and can reach some different parts of the brain cells. We can have cognitive impairments, such as, for example, forgetfulness or slowed motor or cognitive abilities. Problems related to behavior, for example, disinhibition or apathy or depression, or almost every kind of syndrome related to the behavioral area, and also motor impairment, for example, incontinence or tremor or loss of fine motor control, such as, for example, writing. Of course, this kind of syndrome, the dementia, had 6 months survival rate without treatment, but with the treatment adjusted for neurological syndromes, so using therapy that can penetrate the CNS, for example, Integrase Inhibitors or NRTIs, these kind of people can get a longer life expectancy. These kind of symptoms can also be diagnosed by, of course, tests, but also with imaging, because imaging can help to exclude other conditions related to HIV and the CNS. Here we have the first clinical case. So we have this 39-year-old engineer from Belize with problems in his right side, tremor, aphasia, and generalized seizure. It is found that this patient is HIV positive and has 32 CD4. he doesn't have any history of intravenous drug use, and has this imaging, this MRI, that shows this presentation. So there is one focal lesion related to just one part of the brain. I don't know if someone wants to make an hypothesis of what this guy has.
Toxoplasmosis?
I think that is the correct answer. So we are here to talk about, of course, CNS toxoplasmosis. This is very, very common in AIDS patients, around 10% of them, with, of course, an history of toxoplasmosis, because this manifestation is, in fact, reactivation of some infection had in the past. Of course, the clinical manifestation show confusion, show headaches, show focal deficits and seizures. And we will see this particular imaging result with some lesions that are ring enhanced and that have edema around them, that can be localized in every part of the brain, but have a prevalence in the frontal, parietal, and basal ganglia. Of course, the definitive diagnosis can be done with brain biopsy, but if we have positive imaging and clinical presentation and positivity of EGG of toxoplasmosis, we can decide to start therapy. Therapy is done using pyrimethamine and sulfadiazine, and also used with folinic acid to reduce the toxicity of pyrimethamine, and this therapy should be continued until the patient reaches a count of CD4 over 200 and HIV RNA below 50 copies for 6 months. This cerebral toxoplasmosis prophylaxis should be used in every AIDS patient using, of course, trimethoprim sulfamethoxazole or dapsone and pyrimethamine, and should be continued with in patients that had the infection until we know we have this condition I talked before. Another clinical case, so we have this other patient. We don't know if he is HIV positive or no, and he is brought in by his wife and has vomiting, confusion, and this symptom is worsening over the last 9 days. He has got high fever, he is behaviorally not well, and doesn't have a particular presentation, and we see in this CT scan that he has increased intracranial pressure. So we can choose this time with different diagnosis. I don't know if someone wants to make an hypothesis here.
Meningitis.
From which one?
Sorry, meningitis.
Possibility could also be cryptococcal meningitis.
I think you are. I think you are correct. Let's see. Yeah. So we have another opportunistic infection, this time cryptococcal meningitis. Of course, Cryptococcus is a fungus and is associated with meningitis in HIV positive patients with the CD4 cell count lower than 100 this time. And we can have a different kind of symptoms, from totally asymptomatic presentation to photophobia, blurred vision, stiff neck, and skin lesions. Of course, we here can do lumbar puncture because it is a diagnostic and therapeutical approach, as it reduces the intracranial pressure, and can be used, of course, to search for cryptococcal genoma on PCR tests on the cerebrospinal fluid. We have different options for treatment here. Of course, amphotericin B, sorry for the error, and flucytosine for 2 weeks. This is the induction phase. And then we have fluconazole for other 6 weeks. That is the consolidation phase. Of course, this fluconazole should be continued until someone reaches 100 cells, and when we have a viral load below 50. It's important to know that cryptococcal meningitis is one of the conditions where many doctors agree to delay the start of ART therapy, because there is a very high risk of iris, and it is usually delayed until the patient reaches the end of the induction phase. Now we have PML, but I will talk briefly about this because it is, of course, caused by JC virus. So we have same symptoms we have seen before in the other problems related to the CNS, diagnosed by CT or MRI, and of course, here ART should be started immediately because the prognosis of therapy, there is no specific therapy for this, is very poor. After, we have CMV encephalitis. CMV is one, of course, of the infection that appear in people with less than 100 CD4. We can have CMV in many different parts of the body in these patients. For example, in the eyes as retinitis, in esophagus, or as shown here as encephalitis. It is divided into two main forms. So ventricular encephalitis, that has a very rapid and progressive symptoms. There is a confusion that starts very quickly, delirium and focal deficits, or also a polyradiculopathy, so a syndrome that shows mostly in motor defects, weakness in the extremities, paresthesias, and problems to bladder and bowel dysfunction. Of course, here we can have through lumbar puncture the diagnosis, as we can see positive PCR for CMV, and also high level of lymphocytes and proteins. The therapy is used in this infection, ganciclovir and foscarnet together, and until we have improvements. After, we will use secondary prophylaxis with valganciclovir until we reach, of course, immune recovery. After, I think we will start talking about main respiratory complications. Of course, one of these complications is the way HIV was discovered, because the first HIV infection were suspected in some men in the US that had the same presentation, same pneumonia. This pneumonia was caused by Pneumocystis then Carini, now Girovesci, and after this we will talk about quickly other respiratory complications, and then I will leave the word to my colleague. So I will present to you, I think, the last clinical case. This is, of course, the typical presentation of the pneumonia. We have this guy that has discovered that he is HIV positive and presents with the dyspnea, fever, dry cough, and chest pain. And there is no improvement using antibiotics. He goes of course, to the hospital, and we see that he has a very low pulse ox, now 69 in, of course, room air. What we have is a case of Pneumocystis Pneumonia. This was, as I said, the first infection discovered in the people. Then after they discovered that these people were infected by HIV, I wanted to cite this Ugandan study, of course, that find that almost 40% of patients admitted with pneumonia and HIV positive had this positivity for pneumocystis on the bronchoalveolar lavage. Of course, the presentation as the presentation of pneumonia that is not the typical bacterial pneumonia. So a gradual onset with difficult in breathing, fever, cough that is non-productive, and a normal lung exam, and high heart rate. At the CT scan, we find these diffuse bilateral interstitial infiltrates, and is one of the most important causes of pneumothorax in people that are infected with HIV. There are cases when, as someone with pneumothorax and a diagnosis with of HIV gets to the hospital, they discover then that he had this pneumonia. Also, is important to know that if we see cavitations, if we see effusions, if we see adenopathy, we should search for something else. The diagnosis is done using, of course, samples acquired from sputum or from bronchoalveolar lavage, and where we can search for the pneumocystis on PCR test. Of course, clinical diagnosis is possible without these laboratory findings, or also using the fact that we have the clinical findings and that we have a CT scan that is suggestive for PCP pneumonia. What do we do? The main treatment is, of course, trimethoprim sulfametoxazole, the main option, used for 21 days. And also, if the patient, as the patient we have seen in this clinical case, has severe hypoxemia, we can add steroids. And if someone cannot use this antibiotic, the second line regimen is primaquine or with clindamycin. It's important to start antiretroviral therapy, but we have to know that there is also in these cases a risk of iris, of course. And prophylaxis for PCP should be done in people that have less than 200 CD4. And people that had this pneumonia should continue prophylaxis until they reach this count of CD4. Of course, using dapsone or aerosol pentamidine or atopine. The last thing I want to talk about is Megabacterium mavium complex. This is an infection very common in people with a very low count of CD4, less than 50. Almost 25% of people with AIDS and this kind of count get this complex. Megabacterium mavium is one of the 10 non-tubercular mycobacteria discovered, is of course the most common, and can be acquired through inhalation or ingestion and spreads using the lymphatic system. Symptoms of this syndrome include fever, night sweats, weight loss, and also lymphadenopathy and splenomegaly can be found in this kind of illness. And it is possible to make a diagnosis with a positive sample of PCR on sputum, and it can be cured, of course, with a macrolide. Usually it is used clarithromycin and associated with ethambutol for at least 12 months. There are also other non-tubercular megabacteria that have the same therapy regimen that should be continued only for 12 months. Prophylaxis is, of course, used in people who had this kind of infection for 6 months after with clarithromycin and ethambutol. After they reach CD4 count, it can be, of course, suspended, or it is possible to do primary prophylaxis with people who have a very low count of CD4 with azithromycin. The last thing I want to talk is, of course, there were the tumors. Sorry, I forgot them. There is the Kaposi sarcoma, who is associated with human herpes virus 8, and we have this typical laboratory presentation with these typical lesions that can appear anywhere, of course. Also, it is common that we find them in the soles of the feet, or also in the mouth or around on the body of the patient. And they have gastrointestinal symptoms and pulmonary symptoms. Of course, by a biopsy, the malignancy can be diagnosed. And the treatment is, of course, local therapy, if possible, systemic chemotherapy, and the use of ART. And then we have the primary Cns lymphoma. Yes. That is also a high AIDS defining condition, is a non-Hodgkin lymphoma, usually B-cell related, but is not, of course, for everyone. In some unfortunate cases, we have T-cell related lymphoma. And is the more 1,000 more times common than in general population in people who are infected with HIV. So if someone in the general population have lymphoma, say primary CNS lymphoma, for someone with HIV, this possibility is 1,000 times more common. Symptoms may include headache, confusion, memory loss, or seizures. And it is diagnosed via, of course, CT scan and MRI. And it's important to know that has lesions that can be also associated to cerebral toxoplasmosis. But in cerebral toxoplasmosis, we said we had the ring enhancement around them. Here, no, is less evident. The treatment is, of course, the use of ART combined with chemotherapy and steroids for CNS to reduce edema. Of course, this kind of tumor has a very poor prognosis. In fact, median survival for these people is 2 months without therapy and almost 4 years if they start therapy. I think this time is the last slide, of course, the diagnosis, yes. What I have here is the diagnostic protocol for HIV. Of course, everybody here knows about this. What do? We do the first test with the immunoassay. If it is not reactive, there is no HIV infection, so we don't test and again. If it reacts, we do 2 additional tests. If they came back negative, there is no HIV infection. If 2 of the 3 are reactive, we do a confirmatory test by Western blot. If the confirmation is positive, the patient has HIV, and so is the time to start treatment.
My name is Pierluigi, and I'm here to talk with you about the treatment and the prevention of the HIV infection. So let's start with the treatment. The treatment of the HIV infection has been, in my opinion, one of the biggest discovery of the modern world, because it allowed us to transform the HIV infection, which was a sort of death condemned, to a clinical condition which has begun to become chronic and to become a more treatable condition. What are the goals of the HIV treatment? First of all, to prevent the morbidity and the mortality related to the HIV infection. So all the opportunistic infections we saw a few minutes ago, and of course the deaths related to HIV and AIDS. Then to suppress the plasmatic HIV viral load to a level which is called undetectable, which is less than the capacity of the modern tests to detect the HIV in the blood. To restore or to preserve the immunological function, to prolong the duration of life, but most of all, becoming a chronic condition, the most important thing is to improve the quality of life related to the health status. And at the end, but it's important, of course, to prevent the HIV transmission and to stop the pandemic. So what is the treatment? The treatment is the Antiretroviral Therapy, ART, which is the daily use of HIV medicines to treat the HIV infection. The Antiretroviral Therapy is mostly an oral therapy, and it reduces the HIV plasmatic viral load to a level which is undetectable. It reduces the risk of the HIV transmission, because if a patient takes the therapy in a correct way and has an undetectable viral load, it's almost impossible to transmit the virus to other people. It, of course, prevents the transformation of the HIV infection into AIDS and the developing of the opportunistic infections, and it protects the immune system. Above all, of course, it reduces the death events related to the AIDS. You can see in the graphic the comparison between the number of patients receiving antiretroviral therapy from 2000 to 2020, which increased in a very enthusiastic way, and the number of AIDS-related deaths, which of course decreased. So let's see briefly all of the single classes of drugs that we use to treat the HIV infection. The first class of drugs that we're going to talk about are the reverse transcriptase inhibitors. We have two different classes of RTIS, which are the nucleosidic reverse transcriptase inhibitors and the non-nucleosidic. These drugs are inhibitors of the activity of an enzyme, which is specific for HIV virus, which is the reverse transcriptase, DNA polymerase required for the replication of the HIV virus. So they stop the virus in the mechanism of its replication. Then we have another class of drugs, which are the integrase inhibitors. These drugs are inhibitors of the activity of another viral enzyme, which is the integrase. The integrase is an enzyme the HIV uses to let his DNA into the genome of the infected T cells. So with the integrase inhibitors, we can stop the progress of the integration of the genome of the HIV into the genome of the cells, and so we can treat them in another way this infection. A third way we can use is the inhibition of a third viral enzyme, which is the protease. The protease is a viral enzyme of HIV responsible for the mechanism of the capping of the protein precursors, which is necessary for the productions of new mature infectious viral particles. So we have different ways to attack the HIV in its viral life. That's important because we know that the HIV virus is a virus that can develop a lot of resistances to drugs. So the most important thing we have to do in the treatment of this infection is to use different drugs, different also in their mechanism, in order to achieve the goals of the treatment and to obtain a rate of resistance to the drug as low as possible. So now that we know what drugs we have, we can talk about the guidelines that we have to follow to treat the HIV infection. In order to do that, we have to know that the most important thing in the HIV therapy is the concept of combination antiretroviral therapy, which is what I was talking about before. So we have to use different classes of drugs together in order to attack the virus from different points. Another important aspect that we need to keep in mind in the treatment of the HIV infection is the patient itself. So it's the need of the patients, because one of the most important aspects for a good and an efficient treatment of the HIV infection is the adherence, and we'll talk about it later. So it's important to reduce the burden of the therapy using as less pills as possible. The best option, of course, is the regimen that involves 1 pill a day. So we can see here the WHO latest guidelines for the treatment of the HIV infection. We have a first-line regimens and a second-line regimens. The dolutegravir is a drug that the WHO guidelines puts in the first-line regimens, but also in the second-line. The dolutegravir, in combination with 2 NRTIs, which can be nucleosidic or non-nucleosidic, is recommended by the WHO as the preferred first-line regimen for adults and adolescents that are initiating an antiretroviral treatment. If the dolutegravir couldn't be used, we can use another drug, which is efavirenz, who has 2 different doses, but at low dose, which is 400 milligrams, it can be used in combination with, again, NRTIs, so nucleosidic or non-nucleosidic, in order to begin an alternative first-line regimen in all of the patients who cannot use the dolutegravir. So for adults and adolescents with, of course, HIV infection, who cannot use the dolutegravir first-line regimens. For children and infants, the WHO recommends not the dolutegravir, but a raltegravir-based regimen, because the dolutegravir doses for this kind of patients are not still available. The dolutegravir is also the preferred drug regimen for the second-line regimens in patients that didn't achieve a viral suppression using a first-line regimen that didn't contain dolutegravir. So if we have a patient who is doing a first-line regimen with efavirenz, and he is not responding in the way we expect it to do to the treatment, we can switch to a second-line regimen, and we have to do it using the dolutegravir, of course, in combination with NRTIs. In patients using dolutegravir first-line regimens and not responding in an appropriate way to this kind of regimen, the WHO recommends using boosted protease inhibitors, such as darunavir cobicistat, of course, combined with other classes of drugs, such as the NRTIS. And that's the second line for the patients who were using a dolutegravir first-line regimen. So, dolutegravir is the drug that WHO recommends the most for first-line and second-line regimens. Why? That's because the dolutegravir, DTG, combined with two NRTIS in the combination antiretroviral therapy, leads to levels of viral suppression that are lower compared to other kind of treatments analyzed. And another aspect is that dolutegravir-based regimen is connected to a lower risk of discontinuing the treatment by the patient and a lower risk of developing HIV drug resistance compared to the other first-line regimen with evidence among treatments in adults that are initiating the antiretroviral therapy. Other advantages of dolutegravir are a lower potential for drug-to-drug interactions, because knowing now that the HIV infection is becoming a chronic condition, of course, the patient is becoming to assume other kind of therapies for other chronic conditions that are independent from the HIV infection. So it's every day higher the risk to have a drug-drug interaction between the antiretroviral treatment and the other chronic treatment that the patient does. With dolutegravir, this kind of risk is very, very low compared to the other antiretroviral drugs. Then we have a more rapid viral suppression, and higher genetic barrier to the development of drug resistance by the HIV. And of course, the dolutegravir is also active against the HIV-2 infection, which is less common, but of course it's a thing. And the HIV-2 virus is naturally resistant to evidence. So these are the principal advantages of the using of dolutegravir in the antiretroviral therapy. What are the most frequent adverse effects? There's an increased risk for sleep disorders, which is low, but of course is something that we need to keep in mind, knowing that this is a chronic therapy. It has been seen that dolutegravir is linked to weight gain, and the most, I would say, interesting adverse effects of the dolutegravir is the development of neural tube defects in fetuses of mothers taking antiretroviral therapy. We will see it later because it has been a point of discussion in the latest years and months, and we will talk about it later. Then we have the another class of patients, which are patients with HIV infection and a co-infection with tuberculosis. So if co-infection, HIV and tuberculosis is present, and the patient is taking antiretroviral therapy based on the use of dolutegravir, the dolutegravir dose needs to be increased to 50 milligrams twice daily, because the dolutegravir has an important drug-to-drug interaction with rifampicin, that you know is the most common drug used for the treatment of tuberculosis. So we talked about the development of neural tube defects linked to the use of dolutegravir. In the latest years, WHO talked a lot about the use of dolutegravir in during pregnancy, but also in women and girls childbearing age, because it has been seen that dolutegravir has a lot of adverse effects on the pregnancy itself and on the development of the fetus. On the development of the fetus. At certain point, WHO began to discourage the use of dolutegravir in this kind of patients, so in women in pregnancy and in women and girls in childbearing age. But on his latest, on WHO latest guidelines, the dolutegravir regimen, the benefits of the dolutegravir antiretroviral regimen seem to are likely to overweigh the risks. So the dolutegravir is linked to neural tube defects, but is also linked to a greater maternal viral suppression, so a fewer maternal deaths and a fewer maternal to mother-to-child transmission. So on a balance between benefits and risks, the benefits of the dolutegravir regimen seems to overweigh the risks. So dolutegravir is nowadays recommended also in during pregnancy or in women and girls of childbearing age. Of course, this kind of patients needs to be provided with an accurate counseling, giving them appropriate informations and options to enable them to make informed choice about assuming this kind of therapy for a long time. And of course, it's possible to offer this kind of patients who are not in pregnancy a contraceptive regimen of therapy. The other first-line regimen uses efavirenz, which is available in 2 doses, which are 400 milligrams and 600 milligrams. The latest studies showed that the efavirenz 400 milligrams is better tolerated than the 600 milligram dose, and the lower dose has a lower risk of treatment discontinuation from the patient point of view, and a lower incidence of severe treatment-related adverse events. On the other hand, the regimens containing 400 milligrams and 600 milligrams are perfectly comparable for what it concerns the viral suppression, the patient mortality and morbidity, and the principal adverse events, which are the mental and nervous system adverse events. They are both 400 and 600 milligrams. They're both safe to use during pregnancy. And the safety profiles are similar to those of the dolutegravir regimens in terms of pregnancy outcomes and pregnancy adverse events, such as the development of neural tube defects. But most of all, the principal difference that I want to talk with you about is the fact that efavirenz 400 milligrams regimens can be co-administered with rifampicin containing TB treatments. The co-administration in this case is well tolerated, of course, in patients with co-infection, HIV, and tuberculosis that are already in HIV treatment. There are no drug-drug interaction in this case. So we have seen the most recommended regimens, and now I want to talk with you about one of the most important things that we need to keep in mind treating the HIV infection, which is the importance of the patient's adherence to the treatment. That's because a strict and correct adherence to the treatment has a lot of benefits. First of all, it gets the patient to a sustained viral suppression. Taking pills every day reduces the risk of developing drug resistance. it reduces, of course, the incidence of opportunistic infection and the developing of HIV infection to AIDS. And overall, it improves the durability of life and the quality of life related to the health status. On the other hand, it decreases in a significant way the risk of HIV transmission. It's important for us clinicians to try to improve the adherence of the patient to the HIV treatment. To do this, we have to reinforce the importance at every visit for a strict adherence to the antiretroviral therapy in order for the patient to maintain a good health status. Then we have to analyze the adherence of the patient. If the adherence is good, so if we have the laboratory findings that we expect to have in a patient in antiretroviral therapy, we need to reinforce positively the patient. But if we think we have a bad adherence, we need to understand why. So we need to understand if the patient doesn't take the medicine because I don't know, he forgets them, or because he has experienced some adverse effects. In that case, of course, we need to talk with the patient about the opportunity to change the treatment regimen in order to avoid the adverse effects that he's complaining about. We can talk about the prevention if you're there. The prevention of HIV can be done on different pathways. Today, I'm going to talk with you about the prevention obtained using drugs, most of all. And we have two kinds of regimens for the prevention: the treatment as prevention and the pre-exposition prophylaxis. So the treatment as prevention, of course, is concerning the patients already living with HIV infection. So a patient who is HIV positive and who takes his medication daily as prescribed by the clinician is able to get and to keep during time the viral load of HIV in the plasma to a level which is called undetectable. A person who has an undetectable viral load has effectively no risk of sexually transmitting the HIV infection to his or her HIV negative partners. So that's the equivalence between undetectable and untransmittable. Those in the boxes are the principal clinical studies that led us to this knowledge. Of course, the difference are between the patients that have been are related in this kind of studies. But nowadays, the undetectable equal untransmittable is surely a thing, and we need to keep in mind for ourselves, for clinicians, and of course for patients that we treat, and for their families and their families. Then we have to talk about the prophylaxis for persons who are HIV negative. So what's the pre-exposure prophylaxis, also called PrEP? The PrEP is the use of antiretroviral drugs by HIV negative patients in order to reduce the incidence of the acquisition of HIV infection. Of course, it's something that needs to be clearly understood because it has some guidelines that have to be followed. PrEP is recommended for anyone wanting to prevent the possibility of having HIV infection. So for those who are sexually active with an HIV positive partner, so are daily exposed to the risk of taking the HIV infection, or for those who are sexually active with more than one partner, so they cannot be sure about the HIV status of all their partners. For those having anal or vaginal sex and not consistently using protection, so condoms, because of course it increases incredibly the risk of acquiring the HIV infection. And at the end, for intravenous drug users who share with other needles, syringes, or other equipments to inject drugs. The PrEP has about a 99% possibility to lower the risk of contracting HIV when taken consistently, and of course is more effective when combined with other prevention tools, such as, for example, the use of the condoms. So these are the guidelines of the WHO for the use of the pre-exposure prophylaxis. The pre-exposure prophylaxis is the administration daily of an antiretroviral regimen made up of tenofovir and emtricitabine in an oral way. So it's it's 1 pill per day. The indications for assuming the PrEP needs to analyze the past 6 months of the life of the patient. So the patient has to be HIV negative, plus has to have a sexual partner with HIV, or of course a sexual partner with HIV who is not virally suppressed, because we saw that HIV positive patient with undetectable viral load is not infectious, or a sexually active patient who lives in a high HIV incidence or prevalence population, plus any of the we can say the events that can increase the risk of taking the HIV infection. So sexual intercourses without using condoms, most of all with more than one partner that we don't know the HIV status, or a sexual partner with one or more HIV risk factors, or just a history of a sexual transmitted infection, or the treatment of sexual transmitted infection, even the use of post-exposure prophylaxis, so the prophylaxis used after being in contact with the HIV virus, for example, after sexual intercourse without condom, or maybe just in some patients that are just requesting PrEP, because it has been seen that requesting PrEP is a factor that leads to a good following of the PrEP procedures. And so it's a kind of patient that needs to be followed and needs to do the PrEP regimen. Contraindications, of course, are an HIV positivity, because in that case the patient has to do the treatment, not the prophylaxis. And then we have an estimated creatinine clearance lower than 60 milliliters per minute, because these kind of drugs are can be linked to some renal dysfunction. If the patient has some sign or symptoms of acute HIV infection, because they can be the spy for a probable recent exposure to HIV or a probable recent HIV infection, and of course allergy or any other contraindication to any medicine contained in the PrEP regimen, which are the tenofovir and emtricitabine. And the side effects of this kind of drug regimen. The most common are side effects of nausea, abdominal pain, and headache. These kind of adverse effects usually are mild, and they resolve themselves over the first month of taking PrEP without using any other treatment. Then we have that 1 in 200 taking PrEP may have a creatinine elevation, but that's typically reversible if the patient stops to assume the PrEP. And then 1% average loss of bone mineral density that recovers after stopping the prophylaxis. We need to talk about some special situations that we might meet during the clinical practice. For example, if we have a patient who had an exposure to HIV in the past 72 hours, so in the past 3 days, we need to to indicate to that patient the use of the post-exposure prophylaxis if the patient is in the 72 hours after the risk event. So he or she has to use the post-exposure prophylaxis for 28 days. Then, of course, tests for the HIV infection. If the test comes back negative, then he can start the pre-exposure prophylaxis in order to reduce the risk of having the HIV infection. We may have also a patient presenting with an acute viral syndrome. In that case, even if the test is negative, we might consider retesting the patient for HIV after 1 month, or maybe 1 month after resolution of the acute viral syndrome, in order to have a negativity which is consistently true. We might have also patients in pregnancy or breastfeeding. In that case, PrEP is not even a problem, because PrEP can be offered and also continued during pregnancy and during breastfeeding. Of course, during the follow-up, the clinical follow-up of patients assuming PrEP, we need to do some laboratory tests in order to be capable of treating other infections that can be present in the patient. One of the infections that we need to test about is the HBV infection. So if the HBsAg is negative, we need to consider to suggest the patient for vaccination. While if the HBsAg is positive, we need to assess for other exams, and then for HBV treatment indications. Adolescents in particular may benefit from more frequent appointments in order to be sure for a strict adherence, and for be sure for them to know what they're doing in a consistent way. For example, for adolescents, we can talk of monthly visits instead of 3 months visits. So the current WHO recommendations are to use a daily dose regimen, of course, an oral daily dose regimen. PrEP should be offered to patients in substantial risks of HIV acquisition, which is not a risk that is consistently long. So if the patient is no longer in a condition that exposes himself to the HIV infection, he can stop the assumption of the PrEP, and then he can start it again maybe later when he gets himself again in a situation of risk. For PrEP, of course, adherence is important, as it was for the treatment itself of the HIV. So PrEP discontinuation rates are a thing that we need to worry about, and they are often higher in the first 4 weeks of the treatment of the regimen. So the best clinical practice should offer a 1 month supply of drugs, of pills at the first visits when the patient begins to take the PrEP, and then the patient needs to repeat the visits after 3 months and every 3 months. So in the following visits, the clinician has to offer the patients a 3 to 4 months supply in order to let the patient have the pills he needs in every condition. Whether to start the PrEP regimen at the first visit, of course, will depend on the individual circumstances, because, of course, every patient is different from his lab findings, his clinical findings, or his social context. So for the clinical procedure schedule, we have 2 different situations: the initial visits and the follow-up visits. In the first visit, we need to, first of all, we need to assess the HIV status of the patient. So we need to do an HIV test because, of course, PrEP is indicated just for HIV negative patients. Then we need to test for serum creatinine in order to identify pre-existing renal diseases and to be sure that the successive creatinine elevation is not depending on the PrEP regimen. We need to test for HbsAg, as I told before. We need to do an STI screening, so a sexual transmitted infection screening, in order to diagnose infections such as syphilis, gonorrhea, or chlamydia, and to treat them, of course, if they're positive. A pregnancy testing, not because pregnancy is itself a contraindication for PrEP, but in order to guide the prenatal care, or if the test is positive, or to be able to offer a contraceptive counseling if the test is negative. And then we have to do the counseling to, first of all, to assess whether the patient is at the substantial risk to have an HIV infection. Because if we're talking about a patient who doesn't have a risk for HIV infection, the PrEP is mainly useless. We need to discuss the desire of the patient for assuming the PrEP and the willingness to take it in a strict and as prescribed, to assess the fertility intentions in order to, again, offer contraception or safer conception counseling. And then to assess the gender-based violence and the intimate partner violence, which of course are a thing that can lead the patient itself to a substantial higher risk of HIV infection, first of all, and other sexually transmitted infections. For follow-up visits, we need to check other things. We need to confirm the HIV negative status of the patient every 3 months, because of course it's possible to have a seroconversion during PrEP regimens, not because the PrEP is not active against this kind of risk, but of course because the patient may have not a strict adherence, or may have some problems assuming the therapy that leads to a higher risk of contracting the infection. We need to check the side effects referred from the patient to at every single visit, because of course the patient could address some side effects that we need to focus on, and we need to treat if it's possible. A brief adherence counseling done every month in order to reinforce positively the positive adherence. And then we need to check for the estimated creatinine clearance every 6 months. For that, we need to consider our more strict testing, for example, every 3 months or every month, if the patient has itself a history of conditions affecting the kidney. For example, if the patient is diabetic, if the patient has hypertension, these are some conditions that can lead to kidney failure or kidney damage. So we need to be sure that their kidneys are okay. We need to provide screening for sexually transmitted infections. We need to provide counseling about contraceptions or safer conception. And we need, of course, to prevent every other infection that is possible to have during unprotected sexual intercourses. So what are the complications that we can find treating a patient who is assuming a PrEP regimen? First of all, we can find a creatinine elevation, because as I told you before, the PrEP regimen is a combination of drugs that can cause kidney injuries. So we should consider to discontinue the PrEP regimen if the creatinine elevation is confirmed on 2 separate specimens. So if the creatinine elevation is just one single result, we need to repeat again the test on a different specimen. And we need to discontinue the PrEP regimen if the creatinine clearance decreases to less than 60 milliliters per minute. Because as we saw before, a creatinine clearance less than 60 milliliters per minute is a contraindication to the initiation of a PrEP regimen. What to do with this creatinine elevation? Stopping the PrEP assumption is typically sufficient to restore a baseline renal function. So, of course, if the patient has a kidney injury which is independent from the PrEP regimen, the creatinine clearance may be less than 60 milliliters per minute even after the stopping of the PrEP. So once PrEP is stopped, we need to recheck for creatinine levels and calculate the estimated creatinine clearance after 1 to 3 months later the discontinuing, and PrEP can be restarted when the estimated creatinine clearance has returned to normal levels, so above 60 milliliters per minute. Another major complication of the PrEP regimen, as you can see, is the seroconversion. So if a patient turns HIV positive during a PrEP regimen, in this case, an anti-retroviral therapy, as we saw before, can be started without a gap after the discontinuation of the PrEP. So we interrupt the PrEP assumption, and we can definitely initiate an anti-retroviral therapy the day after. So that's the final slide I want to talk with you about, and are the 90-90-90 HIV goals from the WHO. It's a sort of target that the WHO has for the treatment of the HIV infection to help end the HIV and, of course, the AIDS pandemic. Of all the people living with HIV by 2030, so in 9 years, WHO hopes to have the 90% diagnosed, so 90% aware of their HIV positive status. Of this group of HIV positive persons, 90% of them by 2030 needs to be on treatment. So needs to take regularly the antiretroviral drugs. So they need to be capable of getting their treatment daily. Of these people who are HIV positive and who are on treatment, by 2030, WHO hopes to have the 90% of them with a suppression of their viral HIV load in blood, in order, of course, to have some benefits on the patient itself, but on a more generic point of view, in order to help stopping the pandemic and to decrease the risk of the transmission of the HIV infection.